Now we are live with you.
Yes. Okay, good.
Okay, it's 8 now. Can we start it?
Okay. Bismillah ar-Rahman ar-Rahim. Ladies and gentlemen, on behalf of the Saudi Society of Pediatric Gastroenterology, Hepatology and Nutrition board member, I would like to welcome all of you to the SASPGHAN webinar. It is our pleasure in SASPGHAN to conduct this year 2023 scientific educations and our partnership with our colleague, the Biologic company. We'd like to thank Biologic for their partnership and collaboration with SASPGHAN to conduct the first webinar in 2023. However, we already conducted the Pediatric Gastroenterology Club meeting in different cities in Saudi Arabia in this month, 2023. Our talk today, or our webinar, will be about the connecting the dots between the lysosomal acid lipase deficiency and liver disease. It is our pleasure in SASPGHAN to welcome everybody and to start our webinar. Let me just introduce the first speaker. The first speaker is Professor Barbara Borton. She's a professor of pediatrics at the Northwestern University Feinberg School of Medicine and an attending physician in the Division of Genetics. Professor Barbara, she's genomics and metabolism at the Anne and Robert Lewis Children's Hospital of the Chicago. She is also a board certified in the pediatrics. She's also clinical genetics and clinical biochemical genetics. Professor Barbara, she has a clinical and research interests are focused on inborn error of metabolism and newborn screening. Prof. Borton is an investigator in numerous natural history studies and clinical trials of newborn therapies for the various metabolic disorder, including the lysosomal disorders. Prof. Borton, she was the lead investigator in the phase 3 clinical trial of the CB lipase alpha for treatment of the lysosomal acid lipase deficiency, what we call it LALD. She also has published over 200 peer-reviewed articles and 50 chapters in books, and she is an editor of 2 textbooks. Prof. Borton active in professional organizations, and she's ex-president of the Society for Inherited Metabolic Disorder and the Chicago Pediatric Society, and she's served 4 years as a member of the Secretary's Advisory Committee on Heritable Disorder in Infants and Children, and also with the Federal Advisory Committee that makes recommendation regarding the newborn screening in the US, and currently serve as chairman of the Newborn Screening Advisory Committee of the Illinois Department of Public Health. Our Professor Borton, she is an emeritus member of the board of directors of the Greater Chicago Area March of Dimes, and received a Lifetime Achievement Awards for the March of Dimes in 2018. She's a member also of the Scientific Advisory Board of the National MBS Society, and serves on the medical advisory board of of a number of other patient advocacy organizations. Let us welcome Professor Barbara Borton. Welcome, Prof. Barbara.
Thank you so much for that very kind introduction, and thank you very much for the invitation to join you today to talk about lysosomal acid lipase deficiency. I'm going to go ahead and share my screen. Hopefully everyone can see it well, and
yes,
we'll proceed with very good. Excellent. So our topic today is connecting the dots between LDL and ALT elevations and lysosomal acid lipase deficiency. You see my disclosures here. And so just to give you a little overview of what I'll be covering in the next little less than an hour, we're going to first look at two patient cases. We'll talk a little bit about the differential diagnosis between NAFLD, one of the more common liver diseases, and LAL-D. Give you an overview of what LAL-D is like. And when I say LAL-D, of course, I am referring to lysosomal acid lipase deficiency, but that's a lot to say. So we'll frequently use the shorthand descriptor of LAL-D. We'll talk about the diagnosis, a little bit about the histopathology, and then come back at the end to our cases. So the focus of the discussion really will be on recognition of the disorder. But at the end, I do want to share with you some of the clinical trial data related to the enzyme replacement therapy, sabelipase alpha. So first, let's start by looking at a pediatric patient with evidence of liver dysfunction. This is an 8-year-old girl who had a problem with obesity and was noted on a school screening examination to have nucleocanthosis nigricans. So she was referred back to her primary care physician, her pediatrician, who noted again that she was obese. I mean, not horribly obese, but definitely within the range of obesity with a BMI of 23, 94th percentile. And her ALT and AST were elevated, significantly elevated, you see here. Total cholesterol was also elevated at 235 milligrams per deciliter, and her LDL cholesterol was elevated. At this point, she was given recommendations to begin weight reduction and was referred to a pediatric gastroenterologist. By the time she got to the gastroenterologist, she had lost a little bit of weight, but still was in the overweight category. On physical exam, the physician found no hepatosplenomegaly. He conducted an abdominal ultrasound exam, which showed normal echogenicity of the liver and no organomegaly. So some diagnostic testing was performed, as you can see listed here, focused on disorders like autoimmune hepatitis, also infectious hepatitis, alpha-1 antitrypsin was obtained, and ceruloplasmin for Wilson disease. All of those were negative, and so the patient was asked to continue her weight loss program and come back in 6 months. She did so, and 6 months later, the ALT and AST had come down a little bit, but they were still elevated. And at this time, a liver biopsy was performed. This showed a mixed micro and macrovesicular steatosis, minimal lobular inflammation, and stage 1 fibrosis. And it was interpreted as consistent with non-alcoholic fatty liver disease. So the patient again was counseled about weight management and continued on a weight management program. And we'll come back to this patient later, but in the meantime, I'll show you that over the next 3 years, she did have some additional weight loss. She brought her BMI down to the 85th percentile, You'll recall she started at the 94th, but her ALT and AST elevations persisted. Again, they've come down somewhat, now 83 and 61, still elevated. Total cholesterol is still elevated at 200. LDL cholesterol still elevated. So now she has a liver biopsy. This is 3 years later, which shows widespread microvesicular steatosis. The inflammation and stage 1 fibrosis noted on her earlier biopsy are unchanged, but this time on light and electron microscopy, it was noted that there were lipid-filled cytoplasmic vesicles in both the hepatocytes and the Kupffer cells. So the question is, based on the laboratory findings and the medical history, should a patient like this be tested for lysosomal acid lipase deficiency, or should the physician assume that this is non-alcoholic fatty liver disease, NAFLD, which we have, of course, an epidemic of in the United States. We have a tremendous problem with obesity and many patients, even children, diagnosed with NAFLD. So is it appropriate to make that assumption, or should the patient be further tested? And as I say, we'll come back to this a little bit later. Now we're going to change course and look at an adult patient presenting with signs and symptoms of liver dysfunction. This is a young adult male who thought he was completely healthy. He had no significant past medical history, looked fine, felt fine. He was a college student who played college football and was required to get a full physical examination and have some blood tests in order to qualify for the football team. So he was seen by a physician. His BMI was in the overweight range, but this is a very beefy athlete. You know, these football players are big. He was very athletic. His ALT was elevated. You'll see it's 120 units per liter. His LDL cholesterol was also elevated at 150, and his HDL cholesterol was low. It was 30 milligrams per deciliter. On physical exam, he was noted to have mild hepatomegaly. He denied that he used alcohol. Of course, no physician's going to believe that. He's a college student, and you know there's a huge amount of alcohol use among college students in the U.S. at least. But he denied it, and so the doctor counseled him to take a low-fat diet, continue to abstain from alcohol and to pursue some weight loss. And a follow-up appointment was scheduled in 6 months. So the student went back and worked with his athletic trainer. He modified his diet. He did lose some weight. And, you know, again, continued to be asymptomatic. So when he went back to see the physician, his BMI had come down some, still in the overweight range, but lower than previously. His ALT, however, was still elevated. His LDL cholesterol was still elevated. His HDL cholesterol was still low. And he still had mild hepatomegaly on abdominal exam, and again, denied that he had been using any alcohol. So this is a patient really just identified coincidentally to have elevated transaminases, and in this case also the dyslipidemia that you see here. So very often a patient would be referred to a gastroenterologist for further evaluation. So many times, of course, the most likely diagnosis that people consider is non-alcoholic fatty liver disease. But we know that there are many other conditions that need to be considered if you're looking at a patient and you feel that NAFLD is a reasonable consideration. And many of these have been outlined not just in textbooks and so forth, but by professional organizations like yours, like the ones that we have in the U.S. For the pediatric and adult patients. And so some of the other conditions that are often considered are are shown on this slide. We saw in one of our patients that I shared with you, the patient had been assessed for alpha-1 antitrypsin deficiency, quite a common condition. Of course, we can see drug-induced liver disease. So knowing what medications the patient is taking is very important. We can see elevated transaminases in our patients with some of the other inherited metabolic diseases, like fatty acid oxidation defects, although those patients typically have other symptoms such as hypoglycemia, rhabdomyolysis, and so forth. They're not usually completely asymptomatic. Some of our storage disorders like Gaucher disease and glycogen storage disorders might be reasonable considerations if the patient has significant organomegaly. Hemochromatosis, of course, hepatocellular cancer, infectious or autoimmune hepatitis, Niemann-Pick disease would be another one of the storage diseases like Gaucher. Primary biliary cholangitis or primary sclerosing cholangitis, Wilson disease. We saw our first patient was tested for Wilson disease. And then, of course, we have LAL-D. Here we see it listed among the genetic and metabolic disorders. And here again, we just see many of the same conditions listed, many of the medications listed where we can see problems with transaminases or even microvesicular steatosis like we saw in the first patient. These guidelines for considering the disorders that are listed here come from our North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition, SASPGHAN. So they recommend if you are considering a child for NAFL that you think about all of these possibilities, the other metabolic disorders on the list, the various medications that can do this, dietary causes, is the patient malnourished, or has there been recent weight loss surgery? We see increasingly our teenagers are undergoing gastric bypass and gastric stapling, other surgical weight loss procedures, and this would be another consideration. And of course, infectious causes. Alcohol abuse too, we can even see it in our country among the pediatric patients in the pediatric age group. The guidelines for ruling out genetic disorders in a patient considered to have NAFLD in the adult population are seen on this slide, and this comes from the American Association for the Study of Liver Disease. Again, they list many of the same conditions, but you see it listed here depending on whether the patient has macrovesicular or microvesicular steatosis. This, of course, assumes the patient has had a liver biopsy. That is not always the case. Patients may be evaluated, at least in our country, for liver disease, really without the benefit of having a liver biopsy. But if you have a liver biopsy and you see macrovesicular steatosis, the conditions on the left side, are the main ones that you would consider in an adult. And importantly, you don't see LAL-D there. LAL-D falls under the category of microvesicular steatosis. So the characteristic biopsy finding in LAL-D is microvesicular steatosis, which is really different than what we see in alcoholic liver disease. And it's also different from NAFLD. Typically, in patients with NAFLD and NASH, it is typically macrovesicular steatosis, but there is overlap. So patients with LAL-D, for example, can have a mixed micro and macrovesicular steatosis. Some medications, of course, produce a microvesicular steatosis. Historically, years ago, and I'm old enough to have lived through the time when we had patients with Reye's syndrome. We saw it in that disorder, which is now very rare. And of course, you can see microvesicular steatosis with acute fatty liver of pregnancy and help. When you have a patient where you're thinking about NAFLD and you have elevated transaminases, of course, I think looking at the LDL cholesterol is very common. I know I sometimes talk to hepatologists in the US and particularly adult hepatologists, and they'll say, oh, no, everybody has elevated LDL cholesterol. All of our NAFLD and NASH patients have elevated LDL cholesterol. It's just so common in the general population. But the reality is that that is not actually true. And it is much, much more common in LAL-D than in either pediatric or adult patients with NAFLD or NASH. Here you're seeing data on this slide from several studies looking at that issue. You can see on the left side of the slide, 91% of patients with LAL-D have elevated LDL cholesterol above 130 milligrams per deciliter. If you look at pediatric NAFLD patients, that's true in only 21%, and of adult patients, only 16% had elevated LDL cholesterol above 160 milligrams per deciliter. So if you see a pediatric or adult patient with very elevated LDL cholesterol, that should be something that causes you to think carefully about really whether this is the correct diagnosis. If you have not tested previously for LAL-D, this would be a good indicator that that would be appropriate in that patient. We know that the liver disease in LAL-D is progressive and that quite a few patients with LAL-D in the literature have come to liver transplantation because of end-stage liver disease. So the first step, of course, is the steatosis that occurs in the disorder as a result of the enzyme deficiency. Cholesterol, triglycerides accumulate, and the liver is really the primary target. It's not the only target, and we'll talk about the multi-organ system involvement that we see in the disorder in a little bit, but the liver is extremely important. So we start with steatosis, then we begin to see fibrosis progressing to cirrhosis, and finally end-stage liver disease. And the rate of progression is highly variable, and it is also very difficult to predict. So there have been children, certainly, who have required liver transplantation because of LAL-D. There have also been adults in their 60s who've had liver transplantation because of LAL-D. But certainly, if you have serial liver biopsies, you may have a sense of how the fibrosis is progressing to cirrhosis. You can see in an observational study that we did some years back of 48 patients with LAL-D, 31 of them had had liver biopsies, and what we found was that steatosis was evident in almost all of them at biopsy. Fibrosis was seen in the first biopsy in 52%, and cirrhosis was seen in the first biopsy, which was typically done not too long after diagnosis, already in 16% of patients, and 13% of patients had required liver transplantation. Of course, this was a cross-sectional study done at one point in time. That does not mean that some of the other patients would not go on to require liver transplantation at a later time. Now, we know that despite the fact that we have concerns about progression of liver disease in patients with NAFLD and NASH, that it can be slow and certainly appears to, in general, be slower than we see in patients with LAL-D. So if you look at the data shown on this slide, what you're looking at is the percentage of patients who had baseline stage 0 fibrosis who experienced slower versus faster progression. And what you see, and that is defined as slower progression, progressed to stage 1 to 2 fibrosis at follow-up, faster, progressed to stage 3 to 4 at follow-up, and you can see in the NAFLD group, 79% slower, NAFLD, NASH, and so on. So fibrosis in most patients, not all, progresses more slowly, certainly in this group than in the LAL-D patient. So if you see rapid liver progression, again, this is something of concern. And here you see from several different studies in the literature, Bernstein did a large retrospective review of all of the cases of LAL-D published in the literature up to that time, and assessed the fraction of patients who had liver fibrosis or cirrhosis. It was 64%. 29% of the patients reported had cirrhosis. We looked in our cross-sectional study that we published back in 2017 at the fraction of patients who had fibrosis, cirrhosis, or had required a liver transplant. It was 50%. Going down further, you can see a little bit of information on NAFLD and now LAL-D, NAFLD and NASH, excuse me. From one series, 15% with fibrosis or cirrhosis, in another series, 17% with cirrhosis. These weren't all separate studies, they weren't direct comparisons, so we can't exactly compare these numbers, but certainly the sense that you get is that LAL-D patients progress in many cases more rapidly than those with NAFLD or NASH. And this just reiterates this, that putting some of these data together, we found in LAL-D, 50% of patients progress to fibrosis, cirrhosis, or liver transplant within 3 years. With NAFLD, the average time for progression of fibrosis from stage 0 to stage 1 was 14 years. And with NASH, the average time was 7.1 years. Again, separate studies cannot directly compare, but you get the sense that with LAL-D, things progress more rapidly. So let's take a step back. We've been talking about LAL-D as a cause of liver disease that should be considered when you're thinking about NAFLD or NASH in a patient, whether pediatric or adult, but we haven't talked much about really what LAL-D is. So I want to take a step back and talk about the disorder in general. We know this is a disorder associated with significant morbidity and mortality, regardless of the age at which it presents. So it is a potentially life-threatening genetic disease with progressive organ system damage. It's inherited in an autosomal recessive fashion. It is a lysosomal storage disorder, and it's caused by mutations in what is called the lipase gene. This is the gene that codes for the production of the acid lipase enzyme. The estimated prevalence of LAL-D is a number that floats somewhat from time to time. I think we have a hard time knowing for sure what the true prevalence is, but the estimate here is 1 in 160,000 individuals. Other estimates, have been as high as 1 in 300,000, and some even more common than the 1 in 160,000. And this likely varies depending on geography. So certainly the incidence and the prevalence in Saudi Arabia may be different than it is in North America. Historically, this is a disorder that's been referred to using other terms. The term Wolman disease has been used to describe the condition in young infants who have the very most severe form of LAL-D. These are infants with no mutations, no residual enzyme activity, who have a very severe, rapidly progressive disease. And I know we're going to hear from Dr. Ali a little bit later, an example or some examples of Wolman disease in your patient population. And the disorder has been referred to as cholesterol ester storage disease when it presents in children or adults. But like all of our other lysosomal storage disorders, this is a disorder that exhibits a spectrum of severity, and we can have very severely affected young children who you might say have cholesterol ester storage disease, but because they present, let's say, at 2 years of life or 18 months instead of 3 months. But then we have adults who may not present until well into middle age or beyond. So it is a broad spectrum, but those terms, Wolman disease, cholesterol ester storage disease, appear very frequently in the literature. They are the same disorder, but with varying degrees of severity. So you might refer to the infants as having the Wolman phenotype of LAL-D, you know, and the older patients have the cholesterol ester storage disease phenotype. So, of course, what we see in LAL-D is intracellular accumulation of lipids across organ systems. Here you're seeing a diagram of the cell where LDL cholesterol is taken up by the LDL receptor. It's transported to the lysosome. Within the lysosome, we have the lysosomal acid lipase enzyme there, the LAL. Of course, in LAL deficiency, that is not present. Normally, this metabolizes the cholesterol ester and triglycerides. But in the presence of disease, that's not possible. So they accumulate and the lysosomes become enlarged. They're irritating to the cell. And in addition, because they are not degrading the cholesterol esters and producing free cholesterol, they're not degrading the triglycerides, producing free fatty acids, the cell perceives a deficiency, a shortage of free cholesterol and free fatty acids. And so cholesterol synthesis is upregulated. We see upregulation of the LDL receptors in multiple tissues to promote increased cholesterol uptake. So there's significant dysregulation of cholesterol metabolism as a result of this enzymatic deficiency. It impacts the production of VLDL cholesterol. More of it comes out of the cell, less HDL cholesterol comes into the circulation. And the hallmark dyslipidemia that we see in LAL-D is the elevated LDL cholesterol with the low HDL cholesterol. We can see elevated triglycerides, but that is really more variable. So that's what happens in the liver cell, and you see how the liver manifestations really translate to also resulting in the dyslipidemia. So let's talk more about the multisystemic aspects of LAL-D. At least 87% of patients will have the characteristic dyslipidemia that I mentioned: high LDL cholesterol, low HDL cholesterol. Of course, that gives rise to accelerated atherosclerosis. So we can see patients who have myocardial infarction or stroke at an earlier than anticipated age. We see coronary artery disease and aortic disease. We talked about the liver manifestations. Of course, this is virtually 100% of patients have elevated transaminases. They have the hepatic steatosis, either microvesicular or mixed. Hepatomegaly is very common in children with LAL-D. You can see it in adults, but in my experience, many of the adult patients, even at the time of initial presentation, do not have at least palpable hepatomegaly. Maybe on imaging, you would see some mild enlargement of the liver, but you don't feel the liver on physical exam. Many times they turn up just coincidentally, like the case I showed you, because they donate blood and the transaminases are measured, or they go for a routine physical exam. They have chemistries measured, have elevated transaminases. Of course, with progression to cirrhosis, we see the typical things we see with cirrhosis of any cause: esophageal varices, portal hypertension, which can result in splenomegaly and hypersplenism. We have an increased risk of hepatocellular carcinoma as well. Now, when LALD affects a pediatric patient to a significant degree, this can impact growth. So in children, we can see growth failure, failure to thrive. In the severe Wolman form of the disorder, this is very prominent because there is very prominent involvement of the gastrointestinal tract with malabsorption. And so children, young infants particularly, become malnourished, fail to thrive. We also see adrenal calcification very often in these young infants. In the older patients, gastrointestinal manifestations are much less common. You see 22% here, but they do occur. So some of our patients will complain of abdominal pain. They may have evidence of some malabsorption. They may have some vomiting. We do see an increased incidence of gallbladder dysfunction. So more of these patients wind up having their gallbladders removed than in the general population, and some have a history of recurrent diarrhea. Patients with LALD, I think I've said this now several times, they can present at any age. This is a spectrum disorder like all of our lysosomal disorders. In the study that you're looking at on the screen currently, 97 published reports were analyzed, and the fraction of patients who were diagnosed at various ages is noted here. So you can see that the large majority of patients were identified or certainly had clinical symptoms. This is actually the age of the first reported manifestation, not necessarily the diagnosis, but the large majority had clinical symptoms in the pediatric population. The first three bars would be less than 2 years, greater than 2.5 years, greater than or equal to 2 to 5 years, 6 to 12 years, and so on. But we do see patients who have their first symptoms, you know, as old as 41 to 58 years, or even occasionally after the age of 60. And there may be many other older patients who go undiagnosed. I think with all of our lysosomal disorders, we know that the more attenuated phenotypes, the patients with the milder or later onset disorder, are most likely to be underdiagnosed. I think the adult physicians are less tuned in to lysosomal disorders and metabolic disorders in general than the pediatric physicians. Also, of course, we start seeing, you know, so much NAFLD, NASH, alcoholic liver disease in the adult population. And these patients very often, of course, are completely asymptomatic until they have very severe end-stage liver disease. They look normal, they feel normal. They're going to be picked up only by virtue of the laboratory abnormalities, typically. Occasionally some liver enlargement, but often not. And so until their liver disease has progressed to a very advanced state, we know the patients don't typically have clinical symptoms. So the first manifestation could be that GI bleeding from esophageal varices, for example. So let's say you have incorporated all of this information, you know you need to think about LALD and you want to make the diagnosis. What do you do, or how do you do it? Well, the confirmatory test for lysosomal acid lipase deficiency, or LALD, is to measure the lysosomal acid lipase enzyme activity. And there are many laboratories that offer this. It can be done either on whole blood, where it's measured in white blood cells, or it can be done on a filter paper sample, so a dried blood spot. This makes it very easy, of course, if you use that technique to mail the sample to a different site, for example, or to a distant site. It can, of course, also be measured in other tissues like fibroblasts, but that's really rarely necessary. So when dried blood spot testing is done, typically what you see is very low or almost zero enzymatic activity. It's important to remember, though, that sometimes there can be a problem with sample quality, which could cause lower test results. They're usually not absolutely zero, maybe in an intermediate range where you might need to do a second test. You can do genetic testing for mutations in the LIPA gene, and we frequently do this after a patient's been diagnosed, but it's not essential for making the diagnosis. And of course, you can see variants of undetermined significance in the LIPA gene. So unless you get a result that shows 2 known pathogenic mutations where you can be sure that this is a patient with LAL-D, if you start with genetic testing, you're going to typically want to measure the enzymatic activity as well. This is a list of diagnostic laboratories. I don't really know how relevant it is for you where you are living. I mean, this is probably designed for individuals in the United States. You may use some of these same laboratories. I'm just not sure where testing is available for you, but I suspect you're not sending it over to the US where all of these labs offer it. Again, you know, you want to order the LAL-D enzymatic test. We very commonly use electronic medical records over here. I don't know if the same is true for you. Again, if you do, it may be there, but otherwise you may have to specifically provide direction on what the test is that you want and where you want to send it. Okay, I'm going to just kind of skip over this. All right, so the pathology of LAL-D, we talked about liver biopsy and how that can provide clues. Of course, you don't always do that as a first step. If you can make a diagnosis with non-invasive methods, that's always good. And maybe you suspect the diagnosis of LAL-D, get the test, determine the patient has LAL-D. Usually you're going to want to then have a baseline liver biopsy because you're going to want to follow the progression of the liver disease further on. And maybe you do get that biopsy early in the course. And then, of course, we're looking for the finding of diffuse microvesicular steatosis, which may be combined with some fibrosis, even cirrhosis occasionally, or you may have a mixed steatosis, mixed micro and macro. And if you have that, really, you know, you have to step back and think, maybe this really isn't NAFLD or NASH. Maybe this is something like LAL-D or, you know, some of the other things that we showed on the differential of the microvesicular steatosis. And so here you see some photographs taken from biopsy. I know you all are much better at looking at these than I am. I'm a geneticist, not a hepatologist. But you see on the right side here, these lipid-filled lysosomes. And you see the steroid-laden macrophages. You see on the left, there is the diffuse microvesicular steatosis and some bridging fibrosis in this patient. Again, a close-up of the microvesicular mixed steatosis. You see that background of microvesicular steatosis, but then with some large vesicles. And this is different from the typical macrovesicular steatosis of NAFLD or NASH. All right, here is another example from the literature of a patient who had lysosomal acid lipase deficiency. This is a 20-month-old patient who presented with significant hepatomegaly. And when he had laboratory testing at close to 2 years, had quite elevated AST and ALT, you see here in the 200s. Total cholesterol, very high, 282. HDL was low, LDL was high, the typical dyslipidemia of LAL-D. The patient had GI symptoms with vomiting, chronic diarrhea, also had frequent respiratory infections. The diagnosis was confirmed by showing the deficient LAL-D activity. This patient was followed and had some progression on liver biopsy, leading to early cirrhosis at 7 years. At 7 years of age, he was started on a statin, which may have benefit in patients in lowering the LDL cholesterol in the blood. There is no evidence that it has any significant impact on reducing the steatosis in the liver, but it may be beneficial in terms of the dyslipidemia. The patient had progression of the liver disease. You can see moving on with findings up to 24 years of age. So let's go back to the first patient cases I showed you. You remember the 8-year-old girl who had the obesity and acanthosis nigricans, weight loss, really didn't result in resolution of her biochemical abnormalities, which included the elevated transaminases. So based on her liver biopsy that I showed you, LAL-D was considered several years down the line in her follow-up, and she had very deficient or low LAL-D activity. In addition, she had the lipase sequencing, and that showed that she was homozygous for this C894G to A mutation. This is the common mutation that we see in the late onset patients. In other words, not in Wolman disease where we expect the null mutations, but in patients with the cholesterol ester storage disease phenotype. We do see this accounting for about 50 to 60% of alleles. So we see a very large number of different mutations are reported, but this one is fairly common. It's kind of like cystic fibrosis, at least in the US, we have a common mutation. And we do here as well, and she was homozygous for that. So her diagnosis was confirmed. Our adult man who had presented with just transaminase elevations and dyslipidemia, but was asymptomatic, college athlete. Here you can see his test results, his AST, ALT elevated, cholesterol, LDL cholesterol elevated. He did have some hepatomegaly on exam, and he too had confirmation of LAL-D with low enzyme activity. He had testing for Wilson's disease and testing for all of the other infectious and autoimmune hepatitis considerations. All of that was negative. And he also was homozygous for the common mutation in the cholesterol ester storage disease population. So just to kind of wrap that up, here are some of the points that we covered in this review of LAL-D. LAL-D can be severe. It can progress to end-stage liver disease and the requirement for liver transplantation. It can also increase cardiovascular morbidity and mortality. So it certainly can be a severe disorder. It is surely underdiagnosed, particularly in the more attenuated patients who present with biochemical abnormalities in the absence of many findings on physical exam. And it should be considered really in any patient presenting with elevated transaminases and elevated LDL cholesterol, where you might otherwise think about NAFLD or NASH. Testing for the condition is simple. It's relatively inexpensive. It's a biochemical test, and it's definitive in diagnosing the disorder. So we want to make sure we think about it in patients who present with that combination of findings. Now, what about management of LAL-D? We've talked a lot about diagnosis, and of course, we know that there are supportive management options for LAL-D. We heard of some of these being tried in the patients I shared. So low-fat diet, for example, statins and other lipid-lowering agents, which can have some efficacy for the dyslipidemia, but really do not address the hepatic steatosis or the progressive liver disease. Liver transplantation, which has been life-saving, I think efficacious for a number of patients in the literature. Unfortunately, we do not have a lot of long-term follow-up reported for the liver transplant recipients to know if it's really efficacious in treating the non-hepatic manifestations of the disorder. Hematopoietic stem cell transplantation has been utilized in the Wolman phenotype and has been life-saving for a few patients, but generally, because this is such a very severe and rapidly progressive form of the disorder, often the transplant patients didn't live long enough to benefit from transplantation. And we know that none of these therapies really address the underlying enzymatic defect or pathophysiology of LAL deficiency in all tissues. So now we have sibelipase alpha, which is the enzyme replacement therapy for LAL-D. This is indicated for long-term enzyme replacement therapy in patients of all ages. It is contraindicated only in patients with a life-threatening hypersensitivity to the active substance of the drug when you've attempted everything possible to get the patient to tolerate the drug. And I want to say that I've never heard of this happening. I think it is exceedingly rare. We have a lot of strategies we can use to help patients with infusion-related reactions with protein therapeutics like this. So I think, even patients who might, the rare patient who might experience anaphylaxis, and I've had some with LAL-D, we can get through it and we can modify the way that we do things such that the patient can benefit from therapy. But patients who have severe egg allergies, they may be one where you have a contraindication. The drug is actually made in chickens and it's extracted, from the eggs. So there could be some overlap there. So I want to share with you a little bit of the clinical trial data on sibelipase alpha. First, we'll just look very briefly at the study that was done in infants with the Wolman phenotype. There were two separate studies because, of course, these are diseases with very different time courses. So the VITAL study was an open label repeat dose study done in 9 infants who presented with the Wolman phenotype. The primary endpoint was survival at 1 year because untreated, a Wolman patient essentially never lives beyond a year, and that's been documented through natural history studies, chart review. So efficacy was assessed by comparing the survival of the treated patients with a historical cohort of infants with similar characteristics who were not treated. So these 9 infants with LAL-D who had growth failure or other evidence of rapidly progressive liver disease and severe hepatomegaly were treated, and 6 of them survived beyond 1 year. 5 of those continued to receive the drug. There were 4 deaths, all felt to be unlikely related to the therapy. Most of these occurred very soon after patients were started. These were infants who were just too sick to benefit from any treatment at that time. And in these survivors, assessments all the way up to 218 weeks, and some of the patients showed normal scoring on the Denver developmental test. So patients did well. Their GI manifestations, very hard to manage. And I have to say, I was not really involved with this study. This was done by Simon Jones in the UK. But many of these patients required long-term parenteral nutrition and slowly improved. So these are certainly very tough patients. And I'm anxious to hear Dr. Ali's presentation, because just from a quick glimpse at his slides, I know he has experience with these Wolman patients. So I think we'll hear more from him about the treatment of these very severe infants. I was very much involved and was the PI in what we called the ARISE study, which is the phase 3 study of sabelipase alpha in children and adults with LAL deficiency. And these patients are very much more common. At least in North America, the Wolman patients are very rare. And of course, they don't live long. So we have the many more of the older children and adults. And this study was a placebo-controlled trial in a total of 66 patients with 36 randomized to receive sabelipase alpha, 30 in the placebo group. It was a 20-week double-blind period, and then all of the patients rolled over into an extension study where they all received sabelipase alpha. The primary endpoint of the trial was ALT normalization. There were entry criteria that required the patient to have an ALT of at least 1.5 times the upper limit of normal at study entry. So ALT normalization was the primary endpoint. We also looked at changes in LDL cholesterol, changes in non-HDL cholesterol, normalization of AST, looked at triglycerides, HDL. We looked at liver fat content as assessed by MRI. Changes in liver histology were assessed, and changes in liver volume as assessed by MRI. And here you see a plot of the change in the ALT from baseline. And remember, this was 20 weeks. So if you look at the left part of this graph, you have patients who were denoting the baseline as 0. So this is not the ALT value. This is the change from baseline. So at baseline at 0, here this is a decrease. These are negative numbers. And in yellow, you have the patients on placebo who showed very little change in their ALT over the 20 weeks. And you see the patients on sabelipase alpha who had a very rapid and marked decline in their ALT value up to 20 weeks of the study. There was variability, and this is the mean decline in ALT, but I will tell you that every single patient had a decline in the ALT during that 20-week period. Then at 20 weeks, patients from the placebo group were switched over to active drug, and you can see that they come down rapidly also, just like the patients who were initially started on the drug. The percent of patients who achieved ALT normalization in both the double-blind period and the extension study are shown here. You can see that at 20 weeks, 31% had achieved ALT normalization in the treatment group compared to none in the placebo group. By 52 weeks, it was 47%, and then out further in the open label group, you can see we see some stabilization, 47, 51, 45. Everyone has declined, but only about half of them have actually normalized. An interesting finding is that by 100 weeks, 84% of them would not have been eligible for inclusion in the study because their ALT had fallen below 1.5 times the upper limit of normal. The percent of patients with AST normalization followed a similar pattern. You can see it here going up to 68% at 100 weeks. And here you're looking at the impact on lipid levels. What we see when we first start a patient on therapy, here you see the start of therapy and then number of weeks on treatment here, is we initially see a rise in the LDL cholesterol, and then that is followed by a progressive decline. And this is consistent. It was seen in the phase 1 trial also. It's seen also when the placebo patients are switched to active drug here. We think this is due to the rapid mobilization of lipids from the lysosome once enzymatic activity is restored, but gradually over time, we see a nice decline in LDL cholesterol, as well as a nice rise in the HDL cholesterol, which is what we want to see, of course. We have less data really on the progression of the liver disease histologically. There's a little bit here that I'm sharing with you. Here we had a situation where not all patients had liver biopsies and not all had biopsies at the same time points. But what we see is looking at patients who had 20 weeks of sabellopase alpha exposure and had baseline and follow-up liver biopsies, you can see that there were a few who had an increase in their fibrosis score, many who had no change, and a few who had a reduction. If we look at the patients who had a year of exposure, we're starting to see an increasing number who have a 1 or 2 stage reduction in their Ishak fibrosis score. So it's suggestive that at least in some patients, we are seeing improvement in fibrosis, but again, we have really less data. And of course, we don't yet have any data on long-term outcomes. You know, since this is a disorder that progresses over decades, we don't have data on, you know, transplantation risk or mortality from cardiovascular causes. We do have a registry that is attempting to gather real-world data of patients on treatment, and hopefully we'll learn more as time goes on. So with that, I really want to thank you again for inviting me and for your attention. What you're looking at here in my thank you slide is my favorite bird who hangs around my home in Florida. I have 2 homes, one in Chicago where I work and one in Florida where I play. And this is a roseate spoonbill, who I think is beautiful and funny looking at the same time. So thank you, and I'll be happy to address any questions that you might have at this time.
Thank you so much, Prof. Borton. It's really, really very nice presentation, comprehensive and informative. Really, we enjoy it. Thank you so much. There are some questions, if you allow for us, Prof. Barbara. You know, the first question, let me just back to, okay. He said in NAFLD, some elements of fibrosis or inflammation is expected on liver biopsies when ALT is above or more than 80. Is there a cutoff in LAD for ALT or AST as to which fibrosis or inflammation would be expected on liver biopsy?
No, that has not really been demonstrated. So I don't think that we have that information.
Okay, good. The other question, at which age can be present and what early test can be done?
Well, the patient can present as early as, you know, 2 months of age with severe organomegaly, failure to thrive. I mean, it can be rapidly progressing abdominal enlargement. I think you'll hear that from Dr. Ali, or much later in life. And what can be done is rapid diagnosis followed by the sabellopase initiation of treatment just as rapidly as possible. I think in these infantile patients, it's really a medical emergency. So when you see a child who might have appropriate findings, to get the test very rapidly so that you can start the treatment very quickly, because this is very rapidly progressive. And I see the note in the text coming up that Biologic is offering the genetic test for free. If you have a suspected case, you can contact your Biologic representative who can assist with testing.
Actually, you answered the other 2 questions. What is the average? Yeah, what's the average cost of the confirmatory test, and who should go for testing? It's okay. I think the Biologic, sponsoring for this night, this webinar, they are willing and ready to do a test for any suspected patient with liver disease or suspect of LAD disease. Other question, I mean, who should go for testing? What do you think, Prof?
Well, I
Barton?
think we talked a little bit about that as we went along. I think for these infants that present with, significant hepatosplenomegaly who are sick, think about it. I mean, obviously there are some other causes of that, from HLH to, other storage diseases and so forth, but it's easy enough to get this test while you're also getting other tests. So I think you can think about it in that patient. And then in the older patient who shows up with any either hepatomegaly and or elevated transaminases, look at the lipid profile. If you have a patient with elevated transaminases and elevated LDL cholesterol, get the test. Or
Okay.
if you've done a liver biopsy and you have microvesicular steatosis, get the test. I think, so what if you get some tests that come back normal? I mean, of course, you will get some that come back normal. There are other causes, but the importance of making the diagnosis is such that you need to cast really a pretty wide net. And particularly since you can access free testing, why not?
Okay, thank you. There is a question regarding what's the prognosis in case like Anna, that your case presentation,
I think the prognosis for her is good because we do now have enzyme replacement therapy. And even though we don't have the long-term data that tells us that we're going to be able to prevent every patient from having progression of their liver disease, we have every reason to believe that the patients are going to do better if we are removing a lot of this fat from the cell. And I didn't have a chance to show you that we do have a reduction in steatosis in the clinical trials and so forth. If we are reducing the stimulus to irritation and inflammation and so forth in the cell, I think we have every reason to believe that the patients are going to do much better in the long term. So I think the prognosis for her is very good.
Thank you, Prof.
And also for our older
Yeah.
boy as well, the young man who was diagnosed, also for him, I think same way with treatment, I think the patients are going to do much better.
Okay. I have a question, maybe away from LALD. I mean, from your CV as your advisory board in neonatal screening. We have now in Saudi Arabia, we have this program long time, since 90s. Now we extend our neonatal screening up to 16 treatable disease.
Oh.
The question, and is there any few, and those some of metabolic disorder or can be part in the future as in the neonatal screening?
Absolutely. I mean, it could be done in neonatal screening now because there's a test that can be done on the dried blood spots. So we have the testing capability because it's a rare disorder, of course. In many countries, cost comes into play. But I think as we're moving into screening for other lysosomal disorders, for example, in the US now we have widespread newborn screening for Pompe disease and for MPS 1 and MPS 2. Was just added to our recommended uniform screening panel. In my state of Illinois, we do newborn screening for 7 lysosomal disorders. We also do Gaucher, Fabry, Niemann-Pick, and Krabbe, as well as Pompe, MPS 1 and 2. I think there's going to be kits and there's going to be ways of multiplexing a lot of these disorders so we can do the newborn screening simultaneously. And so, yes, I think that is going to be our future. And with a disorder like LALD, that's kind of hard to diagnose because there are many causes for these findings that we've talked about. I think it would be ideal, really.
Okay, that's great and interesting issue, really. That's good. Well, finally, we are in SASPGHAN. Extend our thanks for our guest speaker, Professor Barton, for this nice, comprehensive presentation and the new thing, actually. And all the, comments from all the, attendees, they are happy and they are really thankful for you, Prof. There is one question. Does LALD recur in the liver after liver transplant?
Well, we would not expect that to be the case because the transplanted liver, of course, is going to have normal acid lipase activity, but we don't really have the long-term data. There haven't been reports of what has transpired in these liver transplant recipients beyond usually a very short period of time. So our expectation is that it would not recur, but I think the question is, does it totally address, the cardiovascular? I mean, you should get improvement in the dyslipidemia, but how about the GI tract? Can we still have GI manifestations because you haven't corrected the enzymatic defect there and you haven't corrected it in the endothelial cell? You may still have some vascular involvement. So we don't really know about the other manifestations, but although we don't have the proof, we don't believe that the liver disease should recur.
Okay, thank you so much. I think we are done. Thank you so much for your support and giving this nice lecture.
Thank you so much for having me.
Okay, thank you so much. Now we'll move to the second speaker, Dr. Ali Al-Mhedib. He's a pediatric gastroenterologist and hepatologist at King Faisal Specialist Hospital. Dr. Al-Mhedib is head section of the pediatric gastroenterology at King Faisal Specialist Hospital and Research Center at King Faisal in Riyadh, And Dr. Al-Mhedib, he's also founder of the pediatric gastroenterology hepatology fellowship program in Saudi Arabia. More than 40 pediatric gastroenterologists has been graduated from the program. Dr. Al-Mhedib will give us a talk regarding the RD in Saudi Arabia. Let us welcome Dr. Al-Mhedib.
Thank you very much, Dr. Muad, and I am very happy to be part of this webinar, and it's a great opportunity to have Professor Barbara Borton as a speaker in this webinar. She is one of the world leaders in the disease of lysosomal acid lipase deficiency, and she has a very vast experience in this disease. However, my presentation will be short, and I will discuss lysosomal acid lipase deficiency in Saudi Arabia. And to start with, this is my disclosure in regard to this webinar. And I have written this question, which is very important. Is Wolman disease or lysosomal acid lipase deficiency seen in Saudi Arabia? Yes or no? And the answer is yes, it is seen, and we'll discuss this in the next few slides. To start with, I will present this patient. This patient was seen 8 years ago at King Faisal Specialist Hospital and Research Center, where she was at the age of 28 days. She was born with a birth weight of 2.9 kg, and she presented to the hospital with fever, vomiting, poor oral intake, and poor weight gain. She has no history of jaundice, bleeding, drugs, or herbal ingestion. And her family history is very important because parents are first-degree cousins, and they lost a child at 4 months of age with the same presentation. So now we are dealing with a disease which is most likely an inherited disease. When she was seen initially, she was looking unwell, she was pale, however, she was not in distress, she was not jaundiced or dysmorphic. All her growth parameters were below the 3rd percentile for her age. And, her physical examination was unremarkable apart from distended abdomen and hepatosplenomegaly. And her initial investigation showed, anemia with a hemoglobin of 7.7 with a normal INR, and her, random blood sugar was normal at that time. She has hypoalbuminemia, elevated liver enzymes, normal bilirubin, normal ammonia, and normal lactate. And abdominal ultrasound was done initially, which shows hepatosplenomegaly and mild left kidney hydronephrosis, and bowel loops were distended with fluids. So the patient was admitted, suspected to have sepsis, treated with antibiotics after septic workup. Her vomiting and fever subsided, and the patient was stabilized. And, during her stay in the hospital, she has on and off diarrhea. She was failing to thrive, and she has feeding intolerance associated with abdominal distension. So at that time, the differential diagnosis of the treating team, which were entertained, either it is intrauterine infection, or she has a glycogen storage disease, or lipid storage disease, or other diseases. And, like 8 years ago, we have just introduced our gene testing, and we were debating whether to go for a liver biopsy to look for a diagnosis, especially if you are suspecting lipid storage disease or glycogen storage disease. You may need to do enzymatic assay, etc. And, the genetics testing was just started in our hospital. And we have, difficulty to go which direction, because liver biopsy may give you a clue within 24, 48 hours. How for genetic testing at that time, it takes months to have a result. Fortunately, during the on-call, one of the residents was called because she has increase in her abdominal distension, and she ordered an abdominal X-ray, which is shown here. As you could see, we have a very dilated bowel loops. However, if you concentrate on the middle of the X-ray, you see this big calcification, and this is the other calcification. So she has bilateral adrenal calcification, and this has led us to, stop our progression in liver biopsy, and we, labeled this patient clinically as Wolman disease, as was mentioned earlier, cholesterol ester storage disease in older children and adults. And this was confirmed by gene testing with a homozygous mutation in LIPA gene. So what to do with this patient? Fortunately, the enzyme replacement therapy was available at that time with CB lipase alpha. It was given intravenously once per week over 3 hours, and she tolerated the medication very well. And she showed response in the treatment in the form of increased survival compared to her sibling, improvement in liver and spleen volume, and normalization of her liver enzymes. However, during follow-up, she started to have reappearance or increasing the size of hepatosplenomegaly, and she was diagnosed to have secondary hemophagocytic lymphocytics hemophagocytosis, and this was initiated a bone marrow aspiration, especially with an elevation of the CD25 above 5,000, and bone marrow showed hemophagocytic histiocytic cells compatible with the diagnosis of hemophagocytic lymphohistiocytosis. And she was, treated by our hematologist with cyclosporine, dexamethasone, and this has shown, good response in the form of decrease in her hepatosplenomegaly, increase in her hemoglobin, and normalization of her CD25 and triglyceride. So the patient was a very difficult patient. She has a challenging course with feeding intolerance. She was tried in multiple formulas, but did not show a good result. And at the end, she required TPN for, a very long time to start with. And when you just, summarize her, case, now she is 8 years of age. She is off TPN. She has no hepatosplenomegaly. However, she had failure to thrive. She has short stature, and she was treated with growth hormone by our endocrinologist. She has electrolyte disturbances. She's on supplement, magnesium and calcium. And she developed also gallstone. And one time she was admitted with pancreatitis secondary to gallstone. And, because her, gastrointestinal symptoms was still there, she was referred for, possible stem cell transplantation. So the question whether LALD affects infants only or all age groups was answered by Professor Burton, and this disease can affect any patient. In the past we thought Wolman disease is a disease of infancy. However, it was clearly mentioned in Dr. Burton presentation that it affects older children and adults. So in infants, LALD is rapidly progressive and fatal disease with a median age of death at 3.7 months. Our patient's brother died at 4 months of age because he was undiagnosed. So in pediatric and adult patient with LALD with a clinical biopsy assessment, 50% progressed to fibrosis, cirrhosis, or need liver transplant within 3 years of symptoms onset. And as you could see, it's affect individuals from infancy to adulthood. In infant, it is a rapidly progressive disease resulting in liver failure, premature mortality less than 6 months, with a clinical manifestation of growth failure, hepatosplenomegaly, adrenal calcification, and persistent GI symptoms like vomiting, diarrhea, and abdominal distension, which is the case in our patient. However, in older children and adults, the progression of disease, is resulting in liver disease and lipidemia, fibrosis, cirrhosis, and liver failure requiring transplantation. Unfortunately, because, a lot of patients, they are undiagnosed and they were labeled either cryptogenic, cirrhosis, or they have, elevated liver enzymes of unknown origin. They are followed in different clinics and no diagnosis. And one of the possible diagnoses is liposomal acid lipase deficiency. So we need to put this in mind that if you have undiagnosed liver disease, either in children or even adults, you should look for these metabolic diseases, and LALD is one of these diseases. So as I mentioned, median age at death was 3.7 months. And, in one report by Jones from England, 100% received, stem cell transplantation died before the age of 4 years. And the question comes whether, there are any other modality of treatment. So the exact prevalence of LALD is unknown because, a lot of patients are, underdiagnosed or undiagnosed, and some of them, they die without a diagnosis. And, the studies has reported various prevalence estimates between 1 in 30,000 in Caucasian and Hispanic, up to 1 to 3,000 live births. And the genetic prevalence of known LAL mutation to date predict a higher incidence than the known population levels. And this slide, was mentioned earlier by Professor Pemberton. Almost 20% are seen in the first 2 years of life. However, the rest, the 80%, is older than 2 years of life, and we need to put this as one of our possible diagnosis, although it is rare, but it is a possible diagnosis and it is a treatable diagnosis. And these patients may present with different presentation, including microvesicular steatosis, fibrosis, and cirrhosis. What about gastrointestinal, presentation? Up to 1/4 of these patients may have gastrointestinal symptoms, especially infants. They have abdominal epigastric pain, vomiting, gallbladder dysfunction, like our patient who developed gallstone. It may be from the disease, or it may be from prolonged total parenteral nutrition administration, diarrhea, GI bleeding and malabsorption, failure to thrive, growth failure, also in our patient, cachexia and short stature. So let us see what is available. It was, clearly mentioned that, the introduction of enzyme replacement therapy has changed, the life of these patients, and they are living more with a better quality of life. However, in this report from Royal Manchester Children's Hospital, they have reported 5 patients with Wolman disease, and they have, treated them with enzyme replacement therapy, dietary substrate reduction, and they have improved their survival. However, in 3 out of 5, and the initial response to enzyme replacement therapy was attenuated by anti-drug antibodies with associated clinical and laboratory features of deterioration. 1 patient developed anaphylaxis to the enzyme replacement therapy, and the other patient died after, stem cell transplantation. So because of, HLH. So, and all these patients, 4 out of 5 are alive, and both, disease phenotype and laboratory parameters are improved compared to when they were on enzyme replacement therapy alone. So in such patient, if the patient, especially in infants, they are not responding completely to enzyme replacement therapy, you may consider, stem cell transplantation. What about our experience in Saudi Arabia and the neighboring countries? The first report in 1991 was from Jordan, where they reported 1 infant with Wolman disease. Just to tell you the truth, reviewing the literature, I did not find any patient, older than 2 years of age, described in the literature in our area. So this is the first patient who was, diagnosed with bilateral adrenal calcification. They did the bone marrow, chose foamy cells, and the disease was, confirmed by skin fibroblast culture, which showed decreased acid esterase activity. And the patient died because there was no treatment at that time. The first report from Saudi Arabia was in 1998, at King Faisal Specialist Hospital and Research Center, where they described 4 patients who were diagnosed with Wolman disease, and the diagnosis was confirmed by deficient acid lipase activity, either in the leukocyte from blood or in fibroblast. And the acid lipase activity was less than 6% in all these patients. And this indicates the severity of the disease. One patient, he underwent a liver biopsy, and they have, shown us this, picture where it showed elliptical cholesterol cliffs, as you could see from this slide, distributed all over the liver biopsy. And this, gave a hint to the diagnosis of, Wolman disease at that time. Then another report 1 year later from Bahrain, where they reported 2 cases with Wolman disease, and all of these patients also died. Subsequently, few years later in 2002, another 2 patients were, described from same group in Bahrain. And also one of them, they have the typical, calcification, and the other one showed atypical features with lack of adrenal calcification and unusual morphology of faculated marrow macrophages. So they based, their diagnosis on the clinical presentation and some laboratory testing, but they did not confirm it with genetic testing. This interesting report from our colleagues in Aramco Hospital, where Aramco, this is a unique population. They serve their employee and their dependent. And they have, described the incidence and pattern of inborn error of metabolism in the Eastern Province between 1983 and 2008. So this is almost 25 years. And they described only 1 patient with Wolman disease. And I will come to that, later on. As you could see, they during the study period, they have 165,000 infants born in their hospitals, and they have 1 patient. So the incidence, is 1 in 165,000, which is comparable to other reports from other parts of the world. And recently, a report from SASPGHAN of Wolman disease in a 4-month-old infant with a pathogenic variant G87V, which is the same gene as our patient. Our patient came from Tabuk, which is to the north of Saudi Arabia, and this patient from SASPGHAN, which is to the south of Saudi Arabia. And in Aramco, it is the west, which is close to Bahrain. So close to Bahrain and Eastern Province, you have the disease, and to the north, in Tabuk and in Jordan, we have the disease, and also in SASPGHAN, we have the disease. And this is a report from a dermatologist in National Guard Hospital in Riyadh, where they have, a local association of metastatic Crohn's disease and Wolman disease. And this patient has Wolman disease, which was confirmed by LIPA gene mutation, and she developed, skin disease, continuous manifestation of Crohn's disease, and they describe, this patient also. This meta-analysis was published in 2019 about the global prevalence and the genetic spectrum of lysosomal acid lipase deficiency, a rare condition that mimic NAFLD, which was, very clearly, presented by Professor Burton. And they have, referred to this study from Aramco, where they have only 1 patient in a population of 165,000 patients. So, the prevalence is around this, this figure in our country, which is a possibility because we have in Saudi Arabia, we don't have a clear diagnosis. However, in Aramco, they see these patients. They have good facilities. They have, geneticists. They have gastroenterologists who are well trained, and they can pick, such patients. So, in conclusion, LALD is seen in Saudi Arabia and neighboring countries. It is a life-threatening genetic disease associated with significant morbidities and increased risk for premature mortality. And it is predominantly a pediatric disease with a median age of first reported clinical manifestation of 5 years. And early recognition and accurate diagnosis are critical. You should, have a high index of suspicion if you have unexplained liver disease, and you should look for LALD as a possible diagnosis in such cases. And an enzyme-based biochemical test is used to identify patients with LALD. However, genetic testing is used for confirmation, although it is not 100%, positive. And the liver biopsy for staging and following disease progression is suggested in older children. By this, I will stop the presentation, and thank you. I will be, happy to answer any questions.
Thank you so much, Dr. Ali, for this nice presentation, clear, comprehensive for, Saudi Arabia, experience. There are some questions. Liver transplantation for the late stage of liver cirrhosis. I think this is a general question, maybe. They ask what liver transplantation planned for late stage liver cirrhosis. Maybe, I don't know if they meaning the LALD or in general.
No, I think they mean LALD. Yes, it was answered by Professor Burton. Any patient who has end-stage liver disease, then he or she needs to go for liver transplantation assessment.
Other question: could the LALD diagnosis discover at the date of birth by metabolic screening?
Not to my knowledge, because LALD is not one of the 16 diseases that is, looked for in the National Neonatal Screening Program.
Yes, and also, as you mentioned, Prof, she mentioned that they are started now in state. Maybe in future we have it in our.
Maybe this one recommendation for the Ministry of Health to improve this disease, because it is here and it is patients are dying and undiagnosed. Actually, I have a patient last week who came with hepatosplenomegaly, and he has severe coagulopathy, and the patient brother died at she's 2 months, and her brother died around 3-4 months, and they have lost 2 cousins. And this patient was diagnosed to have tyrosinemia type 1, and it was missed by neonatal screening, because the neonatal screening was done immediately after birth, because they discharge mothers now early, and the recommendation is to do it after 24 hours. That was the only explanation why it was missed. However, we see patients, they are undiagnosed, they die in local hospitals, and no diagnosis is made. However, if you have a good neonatal screening program, then you can pick them.
Okay. Other question: in primary healthcare, is there a rule we can do that discover cases? I think yes. We as we mentioned that you can, if you have any suspicion for any patient suspected to have LALD disease, you can send the test for the company, as appear and mentioned earlier. The biologic company, they are willing to do a test as free for any suspected case. I think even the primary care center, you can communicate them. I think their email in the chat, and it's simple that just call them and they will come. I think as Prof Barbara Borton mentioned, that is dried blood, in the paper, same of the neonatal screening. Well, I think no more question. Finally, I would like to, on behalf of the SASPGHAN board member, I would like to thank our attendees for this webinar. And as we mentioned earlier, this is just the launch, the first webinar. We have a lot of, educational meeting and conferences this year, 2023. And we are also open to have collaboration with different institutes and company. I would like to thank also Biologic Company for sponsoring this webinar. Special thank for our speakers, Prof. Barbara Borton and Dr. Al-Mahedib, and also the people who's behind this webinar, Dr. Dhafir Shihri, who's really, doing this Zoom and all the question. And thank you also for Dr. Ahmed Sultan from Biologic Company. I think we are done. Any comment, anything? I will leave, the floor for our speakers or anyone to comment.
I would just like to say again, thank you for inviting me. I learned a great deal from Dr. Ali, and it was a pleasure being with you for this program.
Thank you very much, Professor, Burton, and we hope that we have a future collaboration. We may invite you to be physically here in Saudi Arabia.
That would be wonderful.
Thank you very much. Thank you, everybody. I think we'll close now. Thank you so much, everybody. Dr. Dhafir, any comment?
Thank you so much. Thank you. Very nice.